think we're ready to get started. As I did my introduction to you in the syllabus, my name is Dr. Richardson. I have lots of experience working in a hospital. I've done many years in cardiopulmonary rehab, diabetes, metabolic disease, obesity. So I'm going to teach this class. I'm going to give you some of the overviews. For many students, this is definitely what you're thinking you want to go into for a career. For others, you're just checking it off the list because you need it for your requirements. I will tell you, every one of you will come into contact with heart disease patients. So at bottom line, you're going to be able to approach somebody with known disease and feel a lot more confident about working with them. So I have the word secondary prevention, and I think it's an important word to let you know because that's really what we're going to spend our semester talking about is working with people what we call known disease. So we call that a secondary prevention program. My guess is all of everyone here in the class, you're doing what we call primary prevention. So primary prevention means you're exercising and living healthy because you're preventing, right? Primary prevention. So secondary prevention is in a cardiac rehab, cardiopulmonary rehab, or just pulmonary rehab. I'm going to go over what happens, like what is rehab, who works there, and what are the 4 phases of rehab. So what we know about cardiac rehab is that there's a lot of benefits. It's going to improve all aspects of how the person feels. We're going to work a lot at doing behavior changes, so lifestyle habits. Usually we're going to see what we call quality of life changes. There's an index called the SF-36. It's a quality of life tool. You give it at week 1, you give it again, 3 months later, and we see after someone's done cardiac rehab that the quality of life goes up. Cardiac rehab is overseen by these 3 organizations, these acronyms you see, AACVPR, AHA, and ACC. The one that you don't see on there is ACSM. ACSM is a great institution. We oftentimes are referring to some of these other more medical-based for higher risk patients. That's where these 3 come in. So we'll take a look a little bit at these organizations. So studies have been shown that people who have a diagnosis, a cardiac diagnosis, are going to see a tremendous benefit from engaging in a cardiac rehab. So whether they have acute coronary syndrome, myocardial infarction, stable angina, heart failure, open heart surgery, a stent, all of these, heart transplant, what we need is a referral. The problem is that we're not getting the referrals we should be getting. So every cardiologist loves rehab, right? It's just like orthopedic surgeons, and physical therapy, right? It's the same thing, right? The orthopedic surgeon and the physical therapy, the cardiologist and cardiac rehab, very similar, lineage. But doctors get busy and they don't always refer like they should. So we're only really seeing about 30% of eligible patients getting into rehab. We will investigate this a little bit with an assignment we'll do later on in the semester about nationwide referral rates, and in looking at what's being done in healthcare right now to, narrow that gap. So rapid transition from hospital into normal life routines, how do we do that? How do we help someone who's come to what we many times near-death experience? Really, cardiac rehab is really what can help them get back on their feet, live independently, get back to work. So the quicker we intervene as workers, right, clinicians in a rehab center, it has been shown to make improvements. Lower hospitalization. So hospitalizations mean revisits, that they get ill again and they got to come back to the hospitals. Depression, recurrent acute coronary syndrome, people who go on disability, people who have a future stroke. Those are just some, many more. But these are all benefits that if we intervene while they're in the hospital, patients, and then get them to come to us later on as outpatients, we really can see a significant improvement in how they feel about themselves, how they'd adhere better to their new lifestyle. A simple thing is getting someone to take their medicine as prescribed. It sounds easy. It's not as easy as it sounds. We see better rates with that. So this slide simply states that there are many data, right? Much data, many different types of research studies have been done. So a meta-analysis demonstrate 25% reduction in cardiac mortality, no big difference in non-fatal heart attacks. But that's only with studies that have looked solely at exercise. They're really looking for another big widespread national study that will look at both lifestyle and education and exercise with the prediction that those percentages would even be higher. So this semester, we're going to look at cardiac rehab, obviously, the name of the class. We're going to look at what are the 4 phases. So phase 1, we'll talk about phase 2, 3, and 4. Phase 2 is really what this class is about, but we'll look at all of them. Phase 3, 4 is what you see more in a fitness facilities. So YMCAs, community centers, Kent State University, they have phase 3, 4. Their college students run it for the community. Phase 1 are people that are in the hospital, newly diagnosed. Phase 2 is really where most of our students are looking to get a job. Bottom line is people are fearful, right? So they've just overcome a very scary part, right? Part of their healthcare journey is they had a heart attack, they've had open heart surgery, and they're afraid that if they exert themselves, that something could happen. So these last 2 bullets tell us, I tell people, I would rather you come to rehab and test yourself, right? Exert yourself in rehab, where we're all there to help. You're on a telemetry unit, we're watching you carefully. Then you go out to the metro parks, or you go, up and down the flight of steps in your home, shovel the snow, mow the lawn. I would rather you first come to us before you try in the community, because that's where you see more fatal accidents happening. If something happens in rehab, we all intervene very, very fast, and it's usually, as you see, only 1 in 900,000 people would have a fatal occurrence, right? Very, very slim chance. So when you think about this class, I want you to think about exercising, obviously, educating, and lifestyle modification. I feel that all of our students, and I'm sure you feel this way about yourself, is you don't have as much information about health education, health literacy. How do you help teach somebody stuff that they need to know in order to make informed decisions on changing their lifestyles? And that is where cardiac rehab, that's what we focus on. So this begins as soon as they're in the hospital, as soon as they're lying in the bed. The education and exercise is beginning. We call that phase 1. So our goal is to try to get them back to life, back to work, back to living independently. We don't want them to go on disability. We don't want them to be re-hospitalized with another heart attack. So we really want them to take accountability immediately to make some changes. Who is involved in all of this? Well, we got the cardiologists, sometimes we have the thoracic surgeons, lots of nurses. You're going to see a lot of nurses employed in rehab centers, exercise physiologists, registered dietitian, psychologist, social worker. We even have a pharmacologist. Pretty much our governing body, who we get our information from, and I encourage you to go to the website, is the American Association of Cardiovascular and Pulmonary Rehab. It's a mouthful, AACVPR. And this organization is really what helps us all, hospitals across the nation, make sure we're delivering sound, data-driven, evidence-based practice. So hospitals can have a certified cardiac rehab. And a certified cardiac rehab means that it's offering everything it should be in its clinic. Usually the certified programs are big hospitals, like here in town, Summa and Akron General, which is now called the Cleveland Clinic. Both of those are certified, right? There is a pretty big city, and they have all the funding they need. Some of them are rural cardiac rehabs, kind of in and around Akron. There's lots of rural hospitals that have rehab. They may not be certified. They're still going to be offering some really good information. But I just want to let you know, anything that's going to be certified is going to go through the AACVPR, the organization. The other 2 organizations that we get a lot of our information from is the American Heart Association and the American College of Cardiology. Ironically, they both came together not too long ago and wrote this really nice paper. It was published in the journal called Circulation. We will read this paper in a little bit. And what this paper does is it takes a look at all the risk factors, right? So risk factors. Heart disease risk factors would be cholesterol, LDL, HDL, triglycerides, total, waist circumference, BMI, blood pressure, glucose levels, stress levels, right? So I could go on and on rattling risk factors, right? Smoking, being sedentary, you know this. And what this paper does is it classifies the different types of risk factors in a secondary prevention program, and it really helps us to understand the role cardiac rehab plays in changing these. So at first read, students get a little confused when they're trying to read this, but it's really kind of grouping these risk factors so we understand kind of how to organize, how to prioritize what risk factors and what we're doing. So our secondary prevention program begins immediately, right in the hospital, right? So they've been diagnosed, they have a heart attack, they've had open heart surgery, and we're going to begin visiting them in the hospital. And then eventually, second bullet, they're going to come back as an outpatient for a maximum of 36 sessions. That would be 12 weeks, 3 times a week, right? So 12 weeks, 3 times a week would be that maximum. So we want to let all of you know that when someone is newly diagnosed with heart disease, they are confused, they are scared, they're very uncertain, they really don't want to exercise, they really have no ambition on joining a rehab because they just feel that if they exert themselves, they might have another heart attack. So all of these kind of myths and fear is really common. So we want to know that. So when you're working and talking with them, you're prepared for that. So what we do in a phase 1, where this is in the hospital, is that we're beginning to just sit bedside with them and talk, right? So we're talking, we're explaining to them what happened, what the procedure was, as long as they're stable and alert, going over, this is what happened. You had an open heart surgery, you had a stent, you had a heart attack, really trying to kind of give them some basic background information. Once they are stable, we get them walking, the word ambulatory, up and down the hall, slow, right? You've seen this happen. In a cardiac floor, they're all on a telemetry unit, so slow walking. We teach them how to breathe, so sitting in the bed and doing some breathing exercises, right? So using lotus spirometry to teach them how to use their lower lobes. Talk about their risk factors, talk about their medication, their new diet, right? They'll tell you, oh, the food here is so yucky. And we'll say, well, yeah, you're on a low sodium diet now. If their family members are visiting in the hospital, we will talk with the family members as well, right? So get more family is aware of what our expectations are, the better it's going to be to get the patient into phase 2. So we're a lot of education, a lot of talking. It reduces anxiety, emotional stress. We talk about risk factors very candidly and politely, very positive attitude. You're trying to really just nurture them so they trust you. If we're able to do some exercises, depending on how they're doing, it's going to be very basic: breathing, relaxation, ankle exercises, range of motion, ADLs. Can they get out of bed? Are they going from the, not letting them lie all day, but getting them up and getting them sitting upright in a chair? Can they walk to the bathroom, brush their teeth, stand for a while, walk up and down the hallways, right? Your basic ADLs. The exercise intensity, really, we're not doing exercise, you're just moving them, but we call that exercise. It's very low level, 2 to 3 METs. So if you're new to this field, right, METs is how we measure exercise, very nice and low MET level. Heart rate stays below 120. RPE is also very low. They're going to be sent, they're going to get discharged, sent home usually, sometimes to a step down unit, depending on if they have nobody to live with. And then we're going to give them the heads up that once you're healed at home, you're going to get a phone call from cardiac rehab, and we're going to expect that you come and you follow up with appointments with us, right? Phase 2 rehab happens after they've healed at home. Many doctors will order a GXT, a graded exercise stress test. It can be done about a month later. Sometimes they do it a little sooner, but really to look at the benefit of how that intervention worked, right? Are they still getting chest pain? Are they feeling better? Why do we do phase 1? As you saw from those last few slides, it's not very strenuous. It's very basic, talking and getting them moving, but data has shown that when hospitals engage in phase 1, we see that they're in shorter stays, less readmission, more confidence, more eager to begin phase 2 rehab. So phase 2, like I said, that's the focus of this class. Outpatient rehab, it begins with a referral. And I've got these 3 bullets that say post, right? So CABG, PTCA, and MI with different dates and time. The time really is up to the doctor. So depending on how the patient did during the procedure will depend on how quickly they can go from their home to driving to and from the hospital to begin with us in phase 2. So CABG is open heart surgery, coronary artery bypass graft, as early as 2 weeks, really as long as 6 weeks. It depends on that sternum is going to get cracked open. So they, we'll talk about this later, but they want that sternum to heal. They need their saphenous vein in their legs to heal. So, maybe a month, give or take. PTCA, PTCI, you might just know this as the word angioplasty or a stent. These letters are kind of a mouthful. It stands for percutaneous transluminal coronary angioplasty. that means a balloon and a stent was put into the heart. And to do one of these revascularization procedures, they can either go right in through the artery and get access and put the balloon and stent in, or commonly in the inguinal crease, which is in, down here in your, you can't see my legs, but anyways, in your growing area, they can go up in through the femoral artery and get access that way. If that's all they've had done, they could have the procedure done on Thursday and be exercising with us in the clinic on Monday. No joke, it really can only just take a few days to heal if they had no actual heart damage. For an MI, it can vary. So maybe a month, sometimes less, sometimes more. An MI depends on where in the heart that happened and the severity. But what you want to know is that you and I, working in a phase 2 setting, that first day we do a full assessment, the physical and oversight of who they are, all the risk factors, and you run a stress test on them. So you do the GXT on them. Then we're going to get them into exercising. So just to go over those common diagnoses. So an MI can begin as soon as the doctor lets us know, right? So myocardial infarction, 3 days a week, heart rate about 40 to 60, heart rate reserve. If they have revascularization, that would cover either open heart surgery, CABG, CABG, or angioplasty stent, percutaneous transluminal coronary intervention, or angioplasty. Again, how many days depends on what happened, right? 2 weeks, days, 4 weeks, it depends. What we're going to see with these guys, similar, is 3 days a week of rehab, and then 3 days a week of rehab along with some exercise. And whenever we can, we're going to add in some strength training with them as well. Strength training would be wall pulleys, TheraBands, light weights, dumbbells. Maximum is 12 weeks. And I say this because more and more insurance companies are covering less and less rehab. So maximum is 12 weeks, 3 times a week, 36 sessions, and covering aerobic, strength training, and education. Every time they come to phase 2, in order for it to be covered by insurance, they must be on a telemetry. So they must have EKG monitoring. We take their blood pressure throughout exercising. You really need to watch. We'll talk about hemodynamics later. You're watching their heart rate, you're watching their glucose levels, you're watching their angina. Everybody's on an individualized program. So, right, what workloads you're doing is all individualized, and they really have a fine, specific guidelines for what we call risk factor modification. So we all serve as a case manager. We all have different patients: smoking, eating, sleeping, stress, cholesterol, all of these things we're looking at. So it's important to participate in phase 2 because we know that it provides so many benefits. One is that they seem to heal, they recuperate much faster. Every person in a rehab, they're in a group setting, so even though they were all strangers on the first day, there's this feeling of comfort that all of them in there have, survived heart disease and are learning how to live their life differently. For many of them, they've never exercised, so they could be in their 70s and totally out of shape, common, and you get them moving and they feel so great. So lots of recuperation, lots of peer support, and every one of them has that case manager, one of us, that's helping them to just make different decisions during the day, eating a little different, sleeping, all of those good things. When you think about who is in the rehab center, they all usually come with a different diagnoses, and we'll go over these in future lectures. But these are your list of common diagnoses or an intervention that somebody may have went through. So angina, congestive heart failure, myocardial infarction, coronary artery bypass graft, that's the open heart surgery. This next list is what you know as PTCA or PCI, the intervention, right? The angioplasty, atherectomy, rotablation, stenting, and many will have a transplant. They're always my favorites to work with, as someone who's had a full transplant. But anyways, so what are the benefits? They get stronger. They heal so much faster. The more you move, the more blood flow you get, the quicker they start healing, gaining more muscle. Quality of life improves. Remember the quality of life index I mentioned earlier? We call it the SF36. It's just a survey tool. So you give the SF36 week 1, you do it again week 10 or 12, and almost every one of these people are going to have, even if they haven't really lost a lot of weight, even if they haven't made a big dent in their diabetes, their quality of life index usually goes up because they're just so much more confident about themselves. Mortality changes, confidence, all of these big things you kind of know. What you need to know, though, is that when we talk in this class about cardiac rehab, I want you to know it's more than just exercise. I know we're all of you are getting an exercise degree right now, but it is a lot more than just teaching an old person how to exercise, right? So education, counseling, lifestyle changes, being a lot of more independence of their own disease process. So they understand their numbers, their cholesterol numbers, their diabetes numbers, all of these things. So lots and lots of education. That's my dog. He's very big, shaking beside me. So what does it look like? It's 3 days a week, maximum 12 weeks. In a group, you'd have about 10 to 14 patients. They come for 90 minutes-ish. Every hospital is a little different, but that would give time for an exercise and a sit-down education session. We need to teach them independence so they're not as reliant on us. So when they come into rehab, over the first few weeks, you teach them how to put on their own EKG patches so they can wear the telemetry unit, right? So there's no wire, but it's a telemetry unit that while they're exercising, we can look at their EKG rhythm. Heart rate, we get a resting blood pressure, we get a resting heart rate, glucose reading. You ask them how they feel every day, subjective feelings every day. How do you feel? Because it can change quickly. Very important question. Did you take your medicine? We'll talk about medication adherence later, but there are many times that they forget. They seem to always forget, but what we want to know is that when they forget their medicine, their hemodynamics are going to change. So we can see differences in their EKG, their blood pressure response. So it's a really important question. And then the last one is very important. I talk about weighing somebody daily. I would never, ever, ever ask you to weigh your clients at your training right now every day. No, 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 don't do that, right? We'd never ask you to do daily weight checks because we know how quickly that can spiral into having more problems. So a daily weight check in a cardiac rehab clinic, what we're looking for is fluid retention. So congestive heart failure patients can gain 4, 6, 8 pounds in one weekend. I mean, they're going to be ill, they're not going to feel good, but getting them on the scale, if you see a giant increase in weight, then you follow it up with, they tell you, oh my gosh, Laura, I am so short of breath. That's a flag that something is going on wrong with your congestive heart failure, and later on we'll talk about it would be a contraindication that they're not allowed to exercise until we get their fluid overload under control. It's a lot of information here on the first day. So phase 2, what does it look like? So it's a room with equipment. You might have 10, 12, 14 patients. You would need at least 3 healthcare providers. Those would usually maybe be 2 nurses, an exercise physiologist, or inverse, depending on where you work, depends on the ratio. So usually on the floor, the exercise floor, is going to be nurses and an exercise physiologist. In Ohio, they seem to really like master's degrees. In other states, Arizona, Florida, I see a lot more a bachelor's degree. So it's kind of depends on who the manager, whether you need a master's or a bachelor's. Most commonly you need a master's. Anyways, and while they're exercising, we're monitoring their blood, their EKGs, their blood pressure, all those things, all those hemodynamics. You're getting them on and off machines. You're making sure they're at the right intensity. Everybody needs to be what we call ACLS, Advanced Cardiac Life Support Certified. This is the certification that you learn to use the paddles, right, to shock someone back. Again, the likelihood of needing to use ACLS is slim. Again, we're in a hospital, so if we call a code, there's doctors all over the place coming to help us. But anyways, that's what the supervision is. Lots of people watching, very different from the rec center or Planet Fitness kind of place. And the exercise looks just what you know, right? Warm up and stretch. The machines you would see: a treadmill, an elliptical, an arm ergometer, a stair stepper, a new step, a rowing machine. I mean, all of the things that you guys know are aerobic machines is what we're going to use. For elderly people, we really do like getting them on what we call non-weight bearing. So the 2 that I just rattled off that don't qualify would be the treadmill and the stair stepper. Stair machine, Stairmaster, whatever you want to call it. We can still get them on there, but understand that depending on their legs, their orthopedic issues, it really can take a toll on them. That's why the rowing machine, the Airdyne, the new step, those are all really nice machines. Anyways, and then you're just charting everything, right? So you're charting all these numbers because in order to prove to the doctor that maybe we're going to get somebody off of medication, we want to really watch the hemodynamics. We want to really have proof and data that their body is doing what it should be doing during exercise. Remember that phase 2 is in a hospital, so they're not living in the hospital, right? They're not inpatient. They live at home, but the clinic itself is usually in the hospital. So if you are driving up Cedar and Locust, which is over where Akron General Cleveland Clinic is, you're going to see right in those windows, you can see the cardiac rehab right there from the window. So we usually have, physicians nearby. We do have a percentage of dropouts. The number one that we see dropout are smokers, and the reason being is smokers, we are on them all the time that we want them to quit smoking. And if they're struggling, they feel like they're letting us, the healthcare provider, down, so they usually quit. I'm telling you that so you know that whenever you're working with a smoker, yes, I want you to help them to quit smoking, but you don't want to be helping them so much that you're nagging. They're not able to keep up with your demands and they end up quitting. So I would rather have a smoker exercising than a smoker smoking and not exercising, right? So we'll talk about smoking cessation later in the class, but it's a fine line. The other big group of people that we see that drop out a lot are elderly that have no support. So not just elderly, but people have no support. So a widow, someone who has no family, those are the ones that usually just kind of don't really put in the effort. So it might take a little more handholding from you. Patients who never miss cardiac rehab are ones where the doctor just says a little bit like, hey, how's rehab going? And hey, how's it going? Or, what are you doing in rehab? Any of those little small dialogues they have in the appointment with the doctor seems to be the ones that are most vested. So that's my quick little synopsis. What I'm asking you to do this week is a very simple project. I would like you, it's not a project, but assignment, I'd like you to hop on YouTube or the internet, whatever you wish. I want you to find a video. I want you to find a cardiac rehab video. Most hospitals have these great little videos that show you the clinic, give you a little bit of background. They kind of used as like a little commercial. Actually, some of my old patients themselves are working in clinics and have them. One of my favorites is one of my students who is up in Michigan in Grand Rapids. She's got a beautiful video and she's got a beautiful clinic, but they're all over. We have some in Ohio, out of state. I don't care what hospital, but I want you to find a video that shows you what a rehab looks like as if you were a patient, so we can kind of understand what the patient's seeing when we tell them they've got to go to cardiac rehab. Your job is to create a new thread on the discussion board, insert the link, the video link, give me a little synopsis about it, and then all of our jobs are to watch them all and talk to each other. So to get full points for this very simple assignment, we have to have some interaction. So I'm asking you all to talk back and forth to each other, ask a question, respond to the question. So you post on Wednesday, and then we all rebuttal Wednesday, Thursday, Friday, Saturday, and by Sunday night at midnight, we wrap up the discussion board. And as long as there's, everyone's interacted a little bit with each other, you get full points. So it's just wanting us to kind of visually see what a rehab looks like. So that's kind of my first video on like what are the 4 phases of rehab. Remember, in this class, we're focusing on